Hello, everyone. It's Dr. Jamil from Cairo, Egypt. I'm with you today to talk about full arch rehabilitation the digital way. I'm very pleased to be with you and with Medit, guys. So, if we are talking regarding how the patient came to us, you may face some issues. So, we may need bone grafting, we may go to graftless approach. So, together, I will go with you like how the patient came and what the expectations, maybe complete denture, maybe a partial or overdenture, or maybe fixed, especially same-day prosthesis. Before going to the treatment, we have to be oriented with the 9 factors for the treatment planning, which is very important to meet the expectations of you, other clinician, and of course, your patient. If we start with this, we will start, of course, with the aesthetics, with the lip support, and with a smile line of the patient, which make a lot of difference in your decision. And a lot of patients today are seeking to do for FP1 restorations or FP3, which is a pink restoration. So first of all, do we need a label support or not? Because if we need a label support, we may have to go for removable, or we need to do grafting to do some support for the soft tissue. As you can see, of course, having a high lid line is very, very difficult if you compare number 6 to number 1. Of course, number 1 is much more easy. In number 6, everything is shown, and here's the decision making whether to go for bone reduction or not for FP1 or FP3. It's like a dilemma of combining both the corridor and the mouse frame, which is the smile, and at the same time, the vertical dimension of the patient. And of course, regarding the All-in-X, what is the ideal number of implants we need to place? Of course, the opposing dentition makes a huge difference, because if your patient is completely dentate, I think we need to add more implants. If your patient have a removable partial denture, have an overdenture, have few remaining teeth, or all-on-4, so we can go for the opposing dentition to be all-on-4. So the opposing dentition is one of the main factors regarding the choice of the ideal number of X for your patient. Then number 3, the available prosthetic space, because sometimes we don't have enough space for multi-unit abutments and they have to go for cement retained. So to do a screw retained implant level versus abutment level, all of us know that abutment level is the easiest for us, the good thing for passivity, but it also needs a good prosthetic space. And sometimes we need to do some bone reduction to create some prosthetic space for long-term stability of our prosthesis. So up till now, we talked regarding the 9 factors. The first thing is the smile line of the patient and the lip support. Do we need the lip support or not? Then we talked about the opposing dentition, and here the fourth is the available prosthetic space, which dictate the type of prosthesis we are going to do, which is either cement retained or screw retained. So by numbers, if we have 15 or more, we can go for most probably FP3 on a multi-unit abutment. If we have 10 to 15, it's FP1, either implant level or abutment level. If it is less, we don't have enough space. And of course, cement retained will be questionable because of repeated decementation of our prosthesis. Then the issue of the cantilever, the triangle, which is dictated by the AB spread or the anteroposterior spread, which is the distance from the anterior implants to the posterior implants. As you all know, we need our full arch prosthesis to be stable enough and to eliminate the cantilever as much as we can. That's why placing your implant is very important to have very good distribution of forces, which stabilize your prosthesis for long term. We always face a problem when we don't have enough bones, such as in the maxilla, we have a normatized sinus, or the mandible, where we have no enough bone above the mental nerve. So here we need to do tilting for our implants or placing short implants to avoid this anatomical structure. So the shape of the arch is always dictate the position of the implant. If you take a look regarding here, when you have a very good bone, this is the AB spread, the distance from the anterior to posterior, there is no problem at all. And this is according to Branamark and then Carl Mesh. This is this ideal distribution for fixed prosthesis, which is modified a little bit with the improvement of the implant system. And this is the ideal position, especially if you are planning for FP1 the plan of your implant, it should be ideally below the future crown. It's not supposed to be in between at the connector. It will end up with a problem in aesthetics and in hygiene, of course. As you can see here in this photo, it shows us that the shape of the arch dictates the distribution of our implants, and you see the cantilever and the AB spread relation. So with a well-formed bridge, when you have a good bone and you have a chance to place your implant in a good AB spread, we nearly eliminated any cantilever, and this is ideal for biomechanical point of view. And this is the main topic for today is FP1 and FP3, pink versus white aesthetics, when and why. Of course, all of us as a surgeons, as a orthodontist, and the patient now oriented by how we need a restoration, which is more or less natural. In the past, the patient are more caring about function, about do the implant will osseointegrate or not, but nowadays we mainly concerned with the aesthetics, the long-term stability of the prosthesis, the soft tissue, the pink aesthetic score, and the patient satisfaction, of course. So it's not about the patient and about us. Of course, all of us are aiming for FP1, but to summarize or to give you like keys, when we have a high smile line, it's very challenging, and we may go to FP1 or FP3. When to do? If you're asking me, the interarch space is the main factor. Do we have a huge interarch space above 15 millimeter? It's not logic to do a very long teeth, especially if we have a large interarch space, and at the same time, our patient is number 1 who has, number 6 who have a high smile line. Okay, so if we have a patient with moderate smile line, we can go more for or low smile line to FP1. As you can see, FP1, normal interarch space, low smile line, and no need for labial support. And the most important, when you are doing planning, you should place your implant just below the future crown. That's why guided surgery is recommended in this kind of cases. And the prosthetic materials, we can go for zirconia, monolithic, isodirect connection, or on a tie base. We can go for porcelain fused to metal or porcelain fused to zirconia if we have a little bit more space. For the hybrid, of course, if your implants are tilted, if you have a challenging interarch space like skeletal cloth 3 cases or high smile line, in this kind of cases, we can go for bone reduction to hide the transition between the natural pink and the artificial pink. And here we need a labial support, and this is a candidate for FP3 cases or pink. So let's see some cases to apply what we have said before. The patient will come in most probably either with 2 scenarios, either completely dentureless with a denture or not, and if he don't have a denture, you have to fabricate him a denture for a planning, and of course to fabricate a prosthesis for immediate loading, such just before the surgery. Or if the patient have a remaining dentitions, for me, it's a game changer, especially if the patient have stoppers. The first step is to take photos and take scans and bite for the patient. This will help you dramatically in fabrication of your prosthesis, of your guides, and for communication with you and with your patient. But take care if your patient have a teeth, make sure that his teeth is not migrated, and do digital smile design to ensure the ideal position in relation to the future prosthesis. So, pink versus white, let's dive together and see how we can do this kind of restorations. Of course, as you can see on the left-hand side, it's FP1. On the right-hand side is FP3 with a pink component. That's always dependent. As you can see in this photo, the soft tissue profile is always meeting the restoration. If you are FP1, you are scalloped, so your restoration should follow and support your scallop soft tissue. But if you are in a situation of FP3, your entire surface or fitting surface should be ultra polished and should be like 2 glass slabs touching each other. Your restoration should be convex or flat, but shouldn't be concave. Never do it concave. Just to be supported with the proper evidence, I will not take too much in this, but we have a very important systematic review regarding the number of implant placed, because we have a lot of debate in this, but nowadays we have like 15 years follow-up, a lot of papers, and with meta-analysis, all of 4 in a maxilla and even a mandible have a compared survival rate, which is ranging from 97 to 99% for the implant and the prosthesis at the same. And as a conclusion of this paper, fewer than 5, which is a group of 4 in maxilla, 3 and even 4 in mandible is a good option, but these key variable elements should be ultimately considered. So to ask you a question, what is the key variable elements? It's the 9 factors which I talked before at the beginning of this lecture, which is again, the smile line of the patient, the lip support, do we need lip support or not? The opposing dentition, which dictates the number of implants you will want to place. Are you going to do splinting for your implants or do segmentation? So you have better option. Of course, the AB spread of your implants and the cantilever length and the screw trajectory and the prosthetic components you are using. So to come with a consensus of ITI, it's very now clear and known to come with a conclusion of that a minimum number of 4 appropriately distributed implants can support 1 full arch. And please, guys, with a all of 4, we should use at least a standard dimension implant, which is 4 by 12. For me, I would go always for longer implants, 16, 18, 20 millimeter implants, so I can engage alpha sites with a good cortical, which is very important to gain a good primary stability for immediate loading. So we will start with the planning and with the implementation of the Medit softwares and the Medit, how we can, the intraoral scanner help us. I usually use it. And as I told you, we can combine it in the pre-operative planning and of course at the post-operative scan for the temporary and of course the final prosthesis. For a completely edentulous patient or patient with terminal dentition, of course, if the patient has a terminal dentition and with some stoppers, at least 2 molars touching each other, we have a good chance to record our bite. Whether to go with a multi-unit, implant level or abutment level, the gold standard is to go, of course, with a multi-unit, especially when we are going for tilted implants or classical Paolo Malo all of 4 or M configuration. So I want to start from the end. So when we are planning for full arch, the maxillary scan, most probably we don't have a problem. Thanks for the rejet area, thanks for the good keratinization. But with the mandible, we need to guide our scanner for a continuous scanning strategy. And I will show you some old classical techniques for continuous scanning strategy. And nowadays with a good support from third-party companies like scan ladders, like Apollo, tries, they are giving us a very good chance to be more or less like with the same, nearly like photogrammetry with a very good outcome and passivity of our restoration. And I will give you some tricks regarding the jaw relation, how to record it digitally, and of course, how we can use our Medit scanner for recording of the face scan of the patient, which is dramatically important in aesthetic zone. Either you are using a single implant bridge, or of course full arch to avoid canting for due restoration. Here's our lovely patient. She is like 30 years old. She is coming complaining from malalignment to her teeth, failed old restorations, open margins, gobby smile, and we need to fix all of this. Of course, the first thing when the patient come in, we should go for a proper planning, digital smile design, and recording some videos. Of course, patients are shy, but we are trying to plan. And as you can see, we are proposed the fully guided digital workflow from the beginning of the surgical part to the prosthetics. And as you can see, we have all the components of the guide, the base guide, where we plan for bone reduction to get rid of the gumminess where the patient complained from primarily. Then we have the implant positioning guide, and of course, the most important, our refabricated restoration for immediate loading. And here's the surgical part where we can open the flap. Here, if we have root, we're still in the era of the maintenance. If you are aiming for FP1, so your main goal is to maintain your sockets, to maintain the soft tissue for a proper contour and proper scalloping. As you can see, we have a lot of soft tissue and a lot of bone. We can make a very good use of this. After cut bone, please don't get rid of this. We can do crushing for it and fill the sockets to maintain the bone contour for very good aesthetics. So we have the 3 guides in one: bone reduction guide, drilling guide here after plateauing and reduction of bone. Then we are placing the drilling guide and the implant positioning. And as you can see, the implants in place. It is an all-in-6, and the multi-unit abutments in place, suturing, and here we can use the PMMA to do immediate loading for our patient. Scanning 3 months later when the patient comes, and here we go. We have a very powerful preserved knife edge papilla between implants, thanks for the soft tissue manipulation, thanks for the socket grafting, and we have a very beautiful, healthy aesthetic restoration even over implants. This can be done doable if you are following these steps. And here's the X-ray for the patient. It's FP1 for the upper arch and FP3 for the lower arch. And here's the smile of the patient. We completely hide the gummy smile and at the same time having FP1 restoration. And here is pre and post. Very happy patient. And this is why we work. This case, we have more details I will go through for you. Here we are. It's fully guided protocol, much more tough case. And as you can see, we are fabricating everything from the beginning. And here it's a little bit different because our patient don't have teeth, only these 3 teeth you can see. And here's the photos with a denture. And the first thing we are doing, of course, to use the patient on denture and use already opaque markers to correlate between the bone which we have and the future crown margins. And as you can see, we have a severely atrophic bone. How we go for a graftless approach. There is an OBG for the patient. It is a retracted view. Maxilla mandible, as you can see, severely atrophic. And this is the data which you need to fabricate your prosthesis, the upper and lower. And thanks for Medit occlusion, we recorded the occlusion using the patient on denture. And as you can see, we have an extra file with the patient denture with the markers, the fitting surface and the occluding surface. At the same, we combining all these data together with the STLs, the DICOM files from the CBCT, so our technician can fabricate for us the surgical guides. Here's the markers, and here's how we combine everything together to fabricate. Let's go for the surgical part, my fun part. And although we are doing a guided surgery, when we have bone of 2 to 3 millimeter buccolingual dimension, I have to open a flap. So as you can see here, in the past, we used to do ridge splitting. I never do this anymore. I will go for more or less for, here's a short video you can see. I go more or less for a palatal approach where we can have a good coverage for the soft tissue. Here is the guide in place, the maxillary guide. We are testing everything. And this is partially guided where we fix the guide, then open a flap where we can see the bone. And here we are securing the guide for drilling. After testing that everything is okay, we went for a subtristed incision where we can easier reflecting the palatal flap. Step by step, you can see all my videos on my YouTube channel, everything, and you are more than welcome to ask me any question. Here's the drilling guided while we are opening a flap. We went for the classical Paulo model, all on 4 with 2 axial frontal implants and 2 tilted implants in the back. We went using Megagen inner-ridge implants, very good design for having a primary stability. Checking the third part, which is the PMMA. And as you can see here, sometimes I'm combining both the Versa drills with a regular drilling kit. It's very helpful and beneficial for condensing the bone, especially in cases of very severely atrophic bone like this. Inserting our implants in a palatal approach, thanks for the very good mucosa. palatal mucosa. Then after implant, we have to check the insertion torque and the resonance frequency analysis using the Austel to measure the true bone to implant contact, which is very crucial in case of full arch immediate loading. As you can see, here is the surgical part into positioning, and here's the mandibular surgery. The same idea, we open the flap, we did plateauing for the bone. The bone is very thin, and we cannot do lingual approach, guys, in the mandible because in the mucosa of the lower arch is very, very thin. We cannot rely on it to cover our implant threads. Here we are, step by step, for the planning of the case. Here is the fabrication of the stackable guides, where we are planning for bone reduction with a 7 to 8 millimeter of bone. And of course, we are expecting, if you understand what I have said few moments ago, you will understand that we will go for FP3, as you can see in this restoration. Of course, after proper profound local anesthesia, of course, we need our patient to be happy. So proper local anesthesia is very important. After opening our flap, guys, don't forget and go and extract the teeth. We need this teeth because our base guide is partially supported on this teeth and partially on the bone. This is very important. As you can see here, we have the one very important landmark in the mandible, which is, of course, the mental nerve. Should see it properly, expose it safely to avoid any injury for it. And here's how we cut the bone. We can make use, as I said before, do crushing and fill the sockets. After cutting the bone, we have very good plateau of bone. We may expect some bleeding, of course. Then, after that, we are placing the second guide. With this guide, fix it in place. Make sure that the guide is very stable. Nowadays, I more or less recommend you to go for metal guides, printed guides. It's much more secure and stable than the resin one or the plastic one. Here is the drilling, step by step, also using the same implant. It's Megagen. We did the surgeries at the same day, so it's tough to do this under local anesthesia, of course. Sequential drilling as usual. In the posterior, you may face a little bit difficulty in the mouth opening. And here is the positioning with our implant, fully guided, supporting the base guide properly, and adjusting the timing of the implant hex for ideal position of the multi-unit above. Of course, with the distal implant should be properly subcrystal to allow for angulation of the multi-unit. And sometimes you need a countersink to build the distal part to allow a proper seat. And here how we're using the insertion torque to show us how the bone to implant contact, can we go for loading or not? I will do summarizing with the Austel. If you are 70 for singles, you can go. For full arch, 60 is okay. For the insertion torque, we need the cumulative insertion torque to be at least 120 Newton per centimeter. For singles, we need 35 to 30 Newton per centimeter. Here's the adjustment of the multi-unit, as you can see. Here we need to do a little bit some bone to allow for a passive seating of the multi-unit. Our implants are very nicely parallel to each other, and we can do pickup for our restoration. Here is the X-ray, and one back clinically to check how it goes. Of course, securing it very passively with the base guide until my lab do some finishing and polishing. Are done with suturing, and we are doing torquing for the prosthesis. And please don't forget to eliminate the cantilever in case of immediate loading. Okay, this is like a summary of the case, step by step, until, and here is how the patient came 3 months later. Everything is beautifully healed. We missed some suture which we will remove, and for the maxillary arch, we don't have a good primary stability, so we went for a secondary surgery to open and choose our multi-unit abutments, doing again modification for the soft tissue. And we here used one very valuable tool, which is the scan flags from Apollo Smart Scan Flags. It's very beautiful for the continuous scanning, especially in the mandible. There's a scanning for the mandible. And here is the FP3 with the reverse scanning. And here is the maxilla. And here is a beautiful thing if you compare the position between the intraoral scan and the extraoral using the reverse scans. It's very nicely matching each other. And this, of course, affect the passivity of your final prosthesis. And here is, let's a little bit, our patient was insisting, although she has a high spinal, high interarch space, or like plus 12 millimeter, but she insisted to go for FP1. So we did some molding, some pressure, and at the same time with the temporary, we have to open the embrasure. And with a beautiful healing, if you take a look on your left-hand side, at the lower of our slide, and on the right-hand side, you can see how beautifully the temporary is very important design to manipulate or to enhance the soft tissue quality, and how we go comparison side by side, the FP1 for the maxilla and the FP3 for the mandible, very beautifully. This is how the intago or the fitting surface looks like. And here is the mandible, the same. Here it's scalloped, here it's convex, as much as you can to avoid any foot entrapment. And let's come to a conclusion. With FP1, guys, full arch rehabilitation, implant positioning is very crucial, guys. Implant positioning is very crucial. SS management, which is socket and soft tissue management. If you are still in the maintenance phase, which means you still have teeth, guys, don't miss this opportunity and do socket preservation and do soft tissue maintenance. And of course, temporization plays an important role to maintain the soft tissue and of course to satisfy your patient. Here's a beautiful how the soft tissue looks like, the pink versus white aesthetics. And here is a post-op OBG 1 year later for this case. And how our patient is very happy with the outcome, and this is pre and post. So let's see the third case, which is a younger patient. She's coming with terminal dentition. This is the smile view and the pose view and the intraoral, as you can see. So guys, answer this question. If we have few remaining teeth, the first thing, guys, don't miss, please do scanning for the upper and lower, and don't miss to record the bite. This will help you dramatically in recording the post-op when you extract all the teeth. This is a pre-operative OBG for the patient. This is a scan, how we record it. And of course, if you need to raise it a little bit with a aid of wax or a composite, you can do it very easy. We did this surgery under local anesthesia, and we'll show you a surprise how we record this during a local anesthesia. Of course, the surgical part with the local with the general anesthesia is easy, but the scanning is not that easy. But I have a surprise for you after 2-3 minutes from now. This is the maxillary flap design, partially flap and partially without a flap. Placing our implant, we have a good bone. Placing the multi-unit abutment with the maxillary all in 6. And with the mandible, we have severely atrophic, especially after flattening of the bone. So guys, we are expecting FP3 in the mandible and FP1 in the maxilla. And here, very important anatomical structure, which is the mental nerve. Guys, take care, don't hit this, please. And this is beautifully how intact is it after placing our tilted implants, how the branches looks like. And here is intra-bony suture to sterilize the soft tissue, because guys, when you reflect your soft tissue below the mucogingival junction, of course, you are expecting coronal advancement, which we will cover the multi-unit, and there is no value from doing this. So with intra-bony suture, we are securing the few remaining transverse tissue to the bone to have a very good fertilization. And here's the surprise of during the GA, we had dual scanning while with open bone, as you can see. The bone is, of course, much more stable than the soft tissue. And as you can see, it was super fast, super easy using Medit I-900 was really surprised, although we have blood, but it's very easy. So guys, if you are opening a flap, especially if you are going for immediate loading, your soft tissue will follow how the prosthesis looks like. So for you, it's much easier if you take your scan on the bone level. And here is the idea of elastics. You can use it for a continuous scan after suturing. Fantastic scan. Here's the maxilla mandible after suturing. This is temporary, the same day. And here's the x-ray when the patient came later. Scanning with a ballo. The ballo is again having a continuous scanning. As you can see, very stable soft tissue profile for the upper, which is scalloped, beautiful. And for the mandible, it's more or less convex to support the soft tissue. Exocan design for the prosthesis. And FP1 for the maxilla, FP3 for the mandible. Beautiful scans. Of course, you need to take a face scan for the patient. Sometimes we even can record the patient eyes. With the temporary, the job's done. You have the temporary, you are supporting the soft tissue. You may need to adjust very small adjustment like the thinnest point in the left central. Other than that, it's very easy done job. Here is the beautiful scans after healing for the pontic sites, and here's the beautiful FP1 and FP3s, how the difference in the intelligo or the fitting surface of our restoration, the beautiful landing for Instagram posts, FP1 maxilla, FP3 mandible, the same. This is video how it looks, how is the difference, just to make clear, because if your lab technician not understand how the difference, you will have a problem in the hygiene and of course in the aesthetics. And guys, implant occlusion is not forgiving. It's not like teeth. We don't have periodontal ligament. So please make sure that your patient you calibrated the occlusion very well. And sometimes when I have to go outside the room and get back to make sure that the occlusion is very well. Sometimes my fellow dentists support me or help me in checking the occlusion for our patient. So as usual, at the dentist, we need to restore aesthetics, function being cost-effective, fast and durable restoration. And of course, this is what our patient deserves. And this is the x-ray for our patient. Happy patient, happy dentist as usual. And this is pre and post cases. So to come up with a conclusion, this is for all the FP1 and FP3 guys who are a little bit confused. For me, FP1, please, you should place your implant just below the future crown. If you are not have very good surgical skills, using a surgical guide or at least a clear denture duplicate can help you to place your implant where the future crown is supposed to be. Then, of course, we will preserve the bone as much as we can. We will support with a socket preservation. Partial extraction therapy plays a very important role. If you have some extracted teeth, you need to support with a GBR or support with a soft tissue graft to maintain these sites or to create these sites for a socket fit restoration. And we are talking about a low to medium smile line and prosthetic space of 10 to 12. If we're talking about FP3, so it's much more easy. Mesodistal implant position is not critical, but you have to make sure that your bone is flat, so your implants are more or less on the same level for a good prosthetic intelligo surface and for a proper distribution of the forces. Excess tissues are always need to be modified. One of the main uses here is intrabony suture, as I told you before. Here we are expecting more prosthetic space, especially if you cut a lot of bone. So we are expecting a metal frameworks to support our veneering material, which may be acrylic, zirconia, or whatever you are using. So this is a conclusion, guys. I hope now it's more or less clear. And I finished my presentation with what we start. For the challenging for full arch cases with the maxilla, most probably it's easy because we have the Roger area as a landmark. With the mandible, we have elastics. We can use a modified scan or scan flags as Apollo, if you have seen, or scan ladders. For the jaw relation, we can, of course, take a pre-operative scan or two scan bodies meeting each other with an impression compound. If not, of course, you can fabricate like a verification jig with studs where you are doing both actions, checking the passivity of your implant positioning, at the same time record the jaw relation using this kind of bars. So here's a maxilla. In this kind of case, it's pretty easy to record the scan for the maxilla. For the mandibular scan, it's a little bit, especially if you are using a long metal scan body, it's not easy. In all of four, if the scan bodies are too away from each other, you can find sometimes difficulties in scanning. So placing an elastics or placing something to guide the scan body for continuous scanning is very important. As you can see, scanning versus reality, how accurate is it? And then doing monolithic direct zirconia, which is nicely passive after this small trick. For the jaw relation, as I told you, usually for me, the ideal is to do pre-operative scan if your patient have teeth, but if the patient don't have occlusion, you can use the classical way, occlusion block, doing splitting, and take two scans, one for the right and one for the left, or sometimes two scan bodies matching each other, or sometimes a scan body which meeting a tooth with an impression compound or green stick or composite. You can very easy record the bite or the jaw relation for your patient, or to be honest with you, at least I'm recording the vertical dimension. I cannot say that it is a centric relation, but at least you have a thing to start from by you doing a temporary, and with a temporary you can fix some of this problem. And this is what I'm talking about, the mill verification jig with the studs, where you can do both functions or both action to check the passivity, at the same time record the prosthesis, record the jaw relation for your patient. And finally, if your patient have a PMMA, you can fix it with immediate loading, even if it's broken, or if the patient have denture, you can use this denture to guide you for doing this kind of jaw relation. And of course, guys, in full arch cases, never let your patient go without face scan. At least you can use with this kind of intraoral scanners, you can use very easy to do face scanning, at least for the nasal. It's a very good landmark for your lab. If you have a face scan, well and good, but at least you have. So guys, by the end, thank you for watching and hope this presentation was very helpful. So keep in touch. This is a QR code for my contacts and for my courses. Keep in touch, guys, and see you in future lectures. See you. Bye-bye.